Hello, everybody, and welcome to this meeting organised by covidaction UK, which is one of the first meetings we've had in a long time, looking at the global situation with COVID. And we've got two guest speakers today from two very different countries, one from India and one from Sweden. We've got Professor Sundararaman Tyagarajan, I hope I pronounced your name properly, who's on the sun-washed coast of South India, and he's from the Public Health Network in India, and he's going to be talking about the situation in India. There's a lot of interest at the moment about what's happening in India, because there seems to be the new subvariant Arcturus causing quite a lot of hospitalizations and so on, and it's now in the UK as well. But there's also the issue of vaccines and many other issues. So I think I'll hand over to you, Sundararaman, and you're very welcome, and we look forward to what you have to say.
Thank you. I'm going to use a PowerPoint, if that's okay. And
you should be able to share screen.
Yeah. Okay.
If that works. There you go.
Right. I didn't know exactly what was expected and pitched to. I'm going to pitch it. I hope it works for you. I'm going to recollect just a couple of facts about the past and then use a few slides to discuss some of the current issues and problems that we are facing. There was a time when I was speaking every week on the COVID-19 for almost 1.5 to 2 years. And now it's almost a long time since I've spoken and updated myself. So thanks for the opportunity. Now, overall, India has been one of the countries most affected by the pandemic. And the official incidence is in the range of 40 million cases and occurred in 2 major waves and 1 minor one. So you can see this is the cumulative graph. You can see one peak happening in the July, August, September of 2020. Another, what we keep using the word brutal for peak, which happened between May, June. And a third, which has not been very much commented on, and we don't know too much about it, that happened in January 2022. You can see this now in terms of active cases. Our first peak was happening at the time of one of the world's strictest lockdowns. Everything but everything was prevented. Didn't quite work because through that, it was the lockdown had its a certain logic that was unusual among countries. We were presumably doing it for what was said to be preventing community transmission, as different from flattening the curve or even from health systems preparedness. So this was a particular logic, but whatever it was, it didn't quite work. And then the second peak took by surprise the system, and it was a huge peak. We had scenes of people struggling in the hospitals. So in the first peak, it was the scenes of people, migrant labor, struggling to get home. That was the dominant visual image. In the second peak was people gasping for oxygen. And then a third peak of which we really don't have a visual account. If one of the big controversies in India has been what was the actual death count, and most academic sources, including I have defended this in many forums, was a 4.7 million excess death. At a time when the government was putting the deaths at 500,000 at about, so there's a huge gap between what government was willing to concede. There's some divergence because excess deaths is not the same as COVID deaths, but even if you were to take as COVID deaths, it would have been much higher. Of which 4.7 million, 830,000 was in 2020, and 3.9 million
Sorry, there's somebody in the background. Can you mute yourselves?
3. In May 2021. This is the scene when we would see fires burning across cremation grounds. You had scenes of bodies floating in the Ganges. But despite that, I mean, these are figures that remain contested. This is just to give a certain background of the immensity of the tragedy that struck. And we still don't know which was worse. Despite so many deaths, the entire lockdown had its own tragic consequences. And we have, therefore, this picture on that. But skipping forward to yesterday, I'm just taking the liberty of jumping right ahead over the period of time. There has been a sharp hike in cases. It was 10,000 yesterday. It was 7,000 the day before on 13th. And 19 deaths in 24 hours. And there is currently over 45,000 active cases. 10 or more districts are reporting from the COVID states. I mean, these are the states that have always, at all phases, phase 1, phase 2, phase 3, still had the reported deaths were higher. So you see zero surveillance, it's a different picture, but 10% positivity in Kerala, Maharashtra, and Delhi, and 5% positivity in the rest. The place where I'm sitting in Puducherry, it's 13% positivity over here. So the pandemic is, quite ongoing in Puducherry as we sleep today. In fact, some hospitalization of a friend we had to vacate because they didn't want us to take the risk of COVID-19. So this is something that is very happening over here today. And we are in a sort of, because of comorbidities in self-imposed quarantine over here currently. Closely tracking one variant of interest, this is slightly earlier, XBB 1.5, which is a parent to the current worry, which is XBB 116. We don't know that this is the main virus causing this upsurge. It's 21.6% in February to 35.8% in March. And every indication is that this is going to be taking over the scenario in a major way. On theoretical grounds, people say there is a risk on the basic structure of this showing immune escape. But in practice, all the studies seem to indicate that there is no particular immune escape or higher case fatality associated with this. The risk comes from the fact that the site of mutation is a site that is very prone, if it were to proceed further, that you could possibly, in a later variant, could do immune escape on that. Now, in terms of genetic variation and what you need to do, this is perhaps it. I'm now going to sort of take you through government strategies currently on the COVID-19 pandemic. The core strategy remains what was declared in 1st April 2021, just before the upsurge. Obviously, it doesn't apply, but you can see the problems of that. For example, testing, and that we will come to when I'll see in surveillance. The testing is very patchy. So we really don't know when we are given a figure, as this is the total number of cases today, whether it is a factor of where testing has happened or whether this is really anyway indicative of the current incidence of the disease. This has been a process right through. Our recommendation has been to have more than 70% RT-PCR. RT-PCR testing capacity dramatically increased in India. Dramatically. In fact, even the indigenous manufacture and distribution of this is one of the great success stories of the time. This did not happen, for example, with ventilators or even with vaccines in the way that happened in RT-PCR, but this is a great one. In tracking, we've really been weak, and in COVID-appropriate behavior, even weaker. But if you see the third column, it is about demarcated containment zones. So last week, the minister announced that there would be containment measures. There would be a repeat of masking instructions, mandatory masking in many areas. But there wasn't any response. I mean, at some point, people have become tired of the thing. And the call for COVID appropriate behaviors doesn't find a response, nor is there any change of the guidelines on how this level of public health management, COVID appropriate behaviors and containment, what are the rules of the game on containment under the current issue. On treatment, of course, there has been a considerable standardization. I think this now across the country, and there's a vast country and with so many variations, but I think this is in place. This particular guideline gets updated frequently, and you can see that it really works well. I'll take you to the bottom of the first column. Do not use in COVID-19. You may notice that in red. There were a lot of remedies that had a popular surge, especially hydroxychloroquine, ivermectin, monoclonal antibodies, convalescent plasma, molnupiravir, zithromycin, doxycycline. Many were being prescribed. Fortunately, most of those have subsided. They have little effect and they are really not big. So mild thing is something that people tend to ignore. And earlier there was quarantine, but now I don't really think much, unless there is self-quarantine, not much happening there. In terms of severe disease, largely, I speak, of course, from the south of India, in a state which is known to be, Puducherry's neighboring state, Tamil Nadu, also known to be well endowed in its health infrastructure. So it's a bit difficult to comment upon this for all of India. Kerala is similar, but for all of India, it's difficult to comment. But what we do know is that the hospital care for COVID-19, severe COVID-19, has improved considerably. And unless there is a dangerous surge of the June 2021 variety, we are likely to do very reasonably well. In fact, there have been drills that as part of preparation in December, there was a call, and then April 10th, 11th, the Prime Minister considered a call and then had a drill. But what is very, very sketchy on what that drill means, because whether it actually does something, it's clear that they are looking at oxygen and ventilators. It is not at all clear whether they have grasped the other levels of problems on the death, their referral transport, the ambulance systems, the admission policies, the intra-hospital infection control. I'm not at all sure whether they have actually learned those lessons very well. And my sense is from the places where we've seen is that it's just about becoming about oxygen. And that, of course, I think they have done a lot in improving the access to oxygen on that. Remdesivir still remains on our protocol with a lot of cautions. And I think tocilizumab is also there, but really in practice, its use is much less. The vaccination policy is another area in which, compared to most LMICs, India has done very well. Partly because we were able to manufacture the vaccines, and you had the healthcare workers in the first phase 1. We started early. By phase 2, everybody above 60 years was being covered. That is in March 21, and 45 to 59 with special comorbidities alone. But soon vaccine availability plus a changing understanding, all persons above age 45 were covered. Phase 3 is a bit interesting. What happened was that persons aged 18 and above were all covered, but the central government said that free vaccine will be available only for that category of age 60 above and 45 to 59. The rest will be led to the market and the private sector. The Supreme Court entered into this issue. I also was one of those people who implemented myself in the proceedings. the Supreme Court demanded the government's position was that this is policy and executive, not a legal issue. The Supreme Court said there has to be a dialogue. They had a dialogue with the state governments. The state government said, we can't manage this load. It went back and forth, and the Supreme Court didn't rule, but seeing the trend of what was happening in June 21, the government declared that it would be free vaccination to all persons age 18 and above. Though in the delivery system, they earmark about 25% for the private sector for delivery. Remember, the private sector provides something like 70% of all outpatient care and 50% of inpatient care. So a 25% earmark for the private sector in vaccine delivery is a rather modest target for them. But in practice, 95% of the vaccination that has happened in the country has happened from the public sector. Much later, children aged 15 to 18 was added, and the precautionary dose for ideally the first health workers and the first category, that age 60 years and 45 to 59 was added on. One important innovation that worked relatively well was the CoWIN portal, the digitization of the whole vaccination effort. This is in great contrast to another digitization effort around the same time that was for tracking COVID-19 cases. That was the Arogya Setu portal, which was a tremendous non-starter. It flopped. But in contrast, this did relatively well, and it has been able to give a reasonable track of this. Net result, both of the after a lot of flips and flops, corrections, they got the strategy right. And what we have now is a claim of a 94.61% primary vaccination, a 87.81% second dose, and relatively low precautionary dose, about 18%. This, we are talking of the eligible population, as different from the total population. If you have total population, it drops to 60-70% on that. But of the eligible population, reasonably reliable figures on this. In contrast to what I was saying about the mortality figures and morbidity figures, and even the case positivity figures, this has been rather thick. Of course, the problem is, given a very understaffed health system, public health system, the fact that the public health system took the entire load of this burden meant effectively that they were diverted into this work from any other work, including maternal and child care. And these disruption in services that occurred right through is one of the biggest problems that are there. There is a reasonable COVID-19 surveillance effort that is in place. I can't comment upon its actual implementation on the ground because it's still happening. The international travel monitoring does happen. It's backed by genomic surveillance. The sentinel surveillance should be the guide for the testing part of it, but that is not quite, I have my worries about it. It has two components. One component says, it's called the P form. I'm not very familiar with how your part of the world, these terms are, how common they are. Are they the same or these Indian terms? What it means is symptom-based reporting of influenza-like illness happens from a large number of facilities in each district. And of the symptom-based, 1 in 20 is submitted to an RT-PCR check. Otherwise, you combine this check with the overall symptom-based reporting to get a spread of the pandemic. The figures I see across the district doesn't give me too much trust. SARI, on the other hand, that is severe acute respiratory infection, is much better monitored on that. Laboratory-based is a sort of separate parallel channel that goes up to the ICMR. That's also reasonably bothered. But together, they get some picture. But I wouldn't say so in the poor performing large northern states, whether they have adequate surveillance effort ongoing. Community-based surveillance, not very sure what actually, I mean, I know what happens there, but not very sure it's effective. Genomic surveillance is something that has taken off in a very big way. They're really doing very well compared to what we expect. Sewage, wastewater, not really there. And zero surveillance is flagged, but after the first few zero surveillances were done quite well, we've not got any further report on that. The genomic surveillance, I have just one slide on this. We have this consortium. The objectives are to track variants among international passengers, also detect early variants in the country. And there is the sentinel sites in the community. So every 15 samples, every 15 days from each district. It's a very relatively small sample for a, India is comparable to Africa in its population and diversity. So in some sense, it is very difficult, but still, it is quite an effort to put it. Obviously, we need to do much higher levels, but this is happening. National level hub and a huge number, 28 labs. The latest count says that it may have gone up to 58. This is my final slide, and actually, perhaps this is where you wanted much of the discussion. But let me say that there is a lot of reasons for concern in our preparedness to face either a re-emergent COVID pandemic or any other new pandemic. First, the whole problem of disruption of services. What happens when we create excess capacity is that all the existing public hospitals, which are providing care to 40% of hospitalization needs, and this 40% is the poorest 40% of the country. That all becomes COVID dedicated hospitals, and the poor get pushed out. There were scenes of even cancer patients getting pushed out of wards for to make them desi. The private sector is relatively reluctant to manage the COVID-19 pandemic, and therefore these cases become designated. This disruption of services, we've not really. So this notion of a surge capacity is still spoken of, but really not there. Second, we really don't know what we have to do with COVID appropriate behaviors. They aren't working. There are many objective reasons why they don't work. Perhaps if we target it better and only look at the probable places of transmission rather than every possible area of transmission, a lot of unnecessary, the whole system of enforcing it actually can permit it. Typically, if you're riding a two-wheeler down a road, you may get arrested for not wearing a mask, which doesn't quite make a difference. You stop your two-wheeler and enter the market. At that time, you need a mask. At that time, the mask, the enforcement is not happening. So there is a whole lot of micro problems on this. The third, and this is the worst, even now we get random. Suddenly somebody says this area is under containment. We really don't have either the process of containment or the triggers of containment or the scales of containment. We really don't know. We've not been able to generalize the lessons we've learned, but we only know containment hurts, and at some point it hurts terribly because there is no social security here. So for 90% of the unorganized sector. So if you close down a particular place, people go hungry because they mostly that day's earnings from, say, selling in the market or sweeping on the streets or domestic work is what supports the family. And therefore, the cost of containment is huge on the poor, very, very iniquitous. And yet we don't have a clear understanding of this. And our testing is somewhat there in the overall structure is there, but its density needs to increase very fast. Finally, the big question, and this question is discussed at the level of policy and academics, is the likely of an immune escape variant emerging. And I hope it doesn't happen because I'm not too sure that we have been able to learn too much from the past. So thank you. I think this is what I wanted to share. The rest I can take with questions on this.
Thank you very much, Sundararaman. there are a lot of questions there, which I'm sure people will have queries about. Lots very interesting, and some parallels with the debates that are going on here as well. So our next speaker is from Sweden. We've been trying for some time to get somebody from Sweden, but finally we managed to get Roger, who I believe was involved with the press group, our press group, for a while, a couple of years ago. The reason why we are curious about Sweden is because the Daily Telegraph and Jeremy Hunt and sections of the Tory party, and also the anti-vaxxers, are very keen on Sweden, holding Sweden up as the model, where Sweden had a very controversial policy at the beginning of the pandemic, led by its health officer, Anders Tegnell, about having no lockdowns whatsoever and so on. And there's been a big debate raging now ever since, which has again resurfaced recently, led by the Telegraph and Jeremy Hunt and so on. So it's very interesting to find out what is actually the truth about what's going on in Sweden. And Roger is active in one of the groups in Sweden. So we're very welcome to have you, Roger, and over to you. I think you're muted. No.
Go to the microphone. Please go to the microphone and click on it. You will find a choice of microphones. Change the choice of microphones. It will be stuck on one, change it. Not the speaker, but the microphone. If you can hear us and we are not able to hear you, it's a problem with your microphone, and that's what works for me. Select a microphone, change the selection there. It may work.
You can hear me now?
Yes.
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 Oh, okay. I don't know. I tested this at least half an hour before, but it worked just fine then. Anyhow, I don't have so many slides though, but as I understand, you're curious about the Swedish approach and how it's turned out. And I can tell you, it's like living in a nightmare, really. Because according to Tegnell, we had the herd immunity, I think it was in March, and then April, and then June, and so on and so on. And he was so damn self-confident, so he even said a specific day when the peak was supposed to be. And the people just getting sick, and the curve went straight up, and he said the peak is now. Oh, sorry, it will be Wednesday or Thursday next week, but that wasn't the truth. And number of people that have died in COVID is way more than the official numbers. I mean, if you were living in the elderly home, for example, getting a urine infection was the same as a death sentence. It's true. I mean, they didn't even get to see a doctor, not even talk to a doctor. There were a few that have relatives that saved them. I mean, if you got for example, a urine infection, they took away your medications and put you on palliative care. It's a nightmarish, really, a real nightmare, this so-called approach. And lockdowns, right, we didn't have any ones, but at the same time, the elderly and the immunocompromised were in the world's longest lockdown, I think. They were not supposed to go out and meet people and so on and so on. So they tried to set up people to go and shopping for them and so on. It didn't work that well though, but somewhat worked. The what do you call it? The municipal have had people that worked that took home groceries for the elderly and so on, but you could only like 10 items from the store, so it didn't work out that well really. And about this excess mortality, it's not true either, because it's a journalist at a newspaper that ordered this graph from SCB, which is the authority in Sweden that have all what you say, all statistics in the country. They they have all statistics, every kind of statistics, and the person who created this graph, who the journalist even wrote to the journalist and said this is not a good way to measure. But the journalist published anyhow, and the Swedish TV and everyone published this graph. I could show you just one thing, at least. This is what's happening if you don't include the death without a known date. You can see yourself. To the left, they have excluded the deaths with the unknown death. To the right, there are included. Sweden is getting higher up on the ladder of excess death, only by including that. So when you see a graph showing Sweden have the lowest excess mortality, I'm sorry, but it's not true. It's a fake graph. They have they have counted the wrong way. Now this don't want to work for me again.
You should have stop sharing at the top of your screen. The top of the Zoom screen.
Yeah, finally I got it.
Yeah.
So that's a few words about Sweden anyhow, and I can also say that there have been extremely gaslighting from the authorities. Today, or the latest months, they have taken away the where they publish the deaths and so on. So it's really hard to get numbers out. You really need to be kind of a private eye to access it. The deaths the latest week are not high, but the test positivity is quite high. We are about, I think, 18% now. When it was the worst during 2020, I think we was about maybe 20. Now we have about 17-18% test positivity. So in a few weeks, I'm afraid that will start rising. Well, I don't know if you have any questions. I am happy to try and answer them.
Okay, thank you, Roger. Very interesting. And the question of excess deaths, of course, is at the center of the debate at the moment. If people have questions for either of our speakers, can you put your electronic hand up so I can see it?
The excess death mortality is about 18%, actually, if you are honest, something like that. Those other numbers, as I said, they are counted. I don't know how really, but there is an explanation about it on Twitter, though. But it's wrong. It's wrong. It's not the truth.
I have a question from Terry. Terry?
Much, Joseph, and thanks very much to both our speakers. Wonderful to share the angst that we feel over here. I've got a few questions, if that's okay, Joseph. The first one for India, I would like to know whether you have antivirals over there, and also the vaccine, the current vaccine. Whether you're actually allowed to get vaccines from your government, and whether public health does the vaccines. Because here in England, we're not allowed vaccines unless we're over 75, or there's a very, very narrow number of people that are allowed, definition of people who are allowed to immunosuppressed, so that's the rest of us can't get the boosters anymore. And then secondly, I'd like to ask about privatization, whether there's privatization in India. I'd be very interested in that. And then for both the speakers, I wondered about the current situation, whether people are wearing masks, whether you go around and see people wearing masks in the public, and social distancing, whether that's in practice, on public transport, at work, this sort of thing. Thanks, Joseph.
Thank you, Terry. Sundararaman, do you want to answer that first?
Yeah, okay. We have largely our vaccines are the Covishield and the Covaxin. Both are indigenous. There is a certain amount of production of Sputnik 5, the Russian vaccine, and there is a Covivax, there's another vaccine there. But these two are dominant on that. So in some sense, nothing. Most of these vaccines are available in the public hospital. You have a precautionary dose allowed, and for comorbidities, they do allow further dose. But there's a long list of comorbidities, but it is above 60 that it is allowed. But there is no offtake of the precautionary dose, and after the second dose, I don't think any person is, very few are opting for it. Reacting to a question on the thing, there are many people's groups which are very active on almost all dimensions of the pandemic. These are known as people's health movements or people's science movements. This is part of a network. The network has more than 300, 400 organizations, but small organizations. Some of them have a larger spread, but we do meet on certain issues, and we do take. So during the initial months of the pandemic, we brought out almost 35 advisories and policy interventions, sometimes condemning the government, sometimes reaching out to people, and position papers on what is happening, and independent position view is put out often enough from this. So I think we've stopped, COVID has gone off the main agenda for the last 6 to 8 months, but otherwise this has been very thing. On masks, I'm afraid it's sporadic. Some people use it to protect themselves, but it is really not there. I mean, in some sense, see, masks are far more effective in preventing transmission from a sick person to another person. And if everyone is not masked, the few people who are protecting themselves won't make too much of a difference. But yes, you do see masks, but there is no implementation, even in hospitals. So while this recent peak happened just this last month, the ministry in the states, the southern states, announced masking compulsory in the hospitals and healthcare facilities. There wasn't much of an uptake of that. So I think that we are going nowhere on that issue on that. So I think these are the other thing. You asked a question on privatization. I can understand, I know the UK system, so therefore the question has a very different meaning here. We must first recognize that ours is a largely private sector in terms of service delivery. And the public sector is a relatively small part. Only 30% of total health expenditure is in the public sector, though it provides care for about 45% of inpatients. That means 55% is in the private sector. This privatization occurs by a process we call passive privatization. There are very few public hospitals that have been handed over to the private sector. That phenomena may still happen because we still have a highly right-wing neoliberal frame of thinking now. So there is some move to do that. But the larger way in which privatization happens is that you do not build additional capacity or staff in the public sector, and the public sector therefore effectively or informally rations its care so that only those who get in, and the rest have to search it out in the private sector because otherwise there's queues. So a district hospital can have on an average 150% bed occupancy. 150% bed occupancy is achieved if you put 2 children or 3 children horizontally on a longitudinal bed. So, or the floors. I was in Dhaka recently. You couldn't even walk the place because of floor patients. So, therefore, people have to spill out and go into the private sector. So therefore, the privatization, we are that way one of the most privatized systems in the whole world. But this has been done by this process of passive privatization, the failed investment. So we have the lowest proportion. The government spend on the health expenditure is less than 1% of the GDP compared to 10% in thing. We are among the 10 lowest countries in the world in proportion of public expenditure on health. So huge problems there.
Thank you very much.
Roger, did you want to answer that question on vaccines and masks?
Yeah, sure. Well, about the masks, we did have sort of a mandate on masks, but I mean, it was kind of a Benny Hill mandate. I mean, it was during rush hours, like 7 to maybe 9 p.m. a.m. Sorry, 7 to 9 a.m. and perhaps like 3 to 5 p.m. And if you, I don't know if you're going to believe me, but I'm telling you, this is the truth, nothing but. If you have booked a seat, you didn't have to have that face mask. I mean, it was really ridiculous. just during some rush hours. And as I said, if you have booked a seat on a train or whatever, you didn't have to use the face mask. About vaccines, now no one under 65 years old is recommended vaccine. If you are under 18 years, it's impossible to get vaccinated. If you are between 18 and 65, you might have, you're allowed to, but you're not recommended. And they have thrown away it's at least 8 million doses. And they have given away to other countries vaccine for children. Instead of vaccinating our own children, they have given it away to other countries. It's like really hard to understand, but you have a pediatrician that have created a report. I think it was early 20. He was cherry picking, so it looked like children didn't get affected, and that report was spread all over the world, I think. That pediatrician stood in the church and talked about herd immunity, and as you can see on this picture, this is what he said. He's supposed to be a pediatrician. He's signed the Great Barrington Declaration. I mean, would you believe it? It's, as I said, it's a bloody nightmare, this country. Gaslighting is unbelievable. The general director for the Swedish CDC was asked whether or not she would take her third dose, and then she answered that she wasn't sure about it. And the person that took in the vaccines to the country, he was like really mad, because such a statement does do people don't feel like they need to take the vaccines. I mean, if the general director of the Swedish CDC says, I don't know if I'm going to take it, I've not decided yet, and maybe it's okay with the 2 initial doses.
Thank you, Roger. Yeah, that's some pretty horrendous, some of it. Are there any other questions for our speakers? If you can put your hand up. Well, I don't see any other hands. I'm going to put a question to Roger first. So Roger, I think the reason why Sweden is held up as the ideal by many of the anti-vaxxers is for some of the reasons that you stated already, that there seems to be an active discouragement of people to take vaccines. And that seems to be borne out by what you've said. There's also the issue of containment and lockdown, I mean, which Sundararaman has addressed as well, where Sweden, is very much seen as the leading country in the argument that lockdowns don't work or are not effective or whatever. And I suspect that is the model that will be used in any future, if there's another variant, or if there's a flu pandemic or whatever, they will try and sort of spearhead that movement, which is very popular, of course, with the anti-vaxxers and the far right, and the right-wing elements, neoliberal elements in the Tory party, whose basic, argument is that nothing must affect the economy in any way. So, I mean, Tegnell is always held up as the main creator of this, but I mean, is the current regime there? He's left now, but are they still carrying out his policies? And what you mentioned about the care homes, I mean, it's horrendous. I also heard that they gave many people morphine. They effectively carried out euthanasia on a vast scale. And my worry is that that's the model, you know, if the Swedish model is adopted, that will be the model going forward.
Yes, that's the truth. They let people suffocate to death. Really, it's horrible. Really, really horrible. There are not words for it. And I mean, they put up a military hospital in Stockholm. They didn't use it for some reason. Well, they did for a few patients, and they killed one patient in it also because he was on oxygen, and what do you say, host, it was old equipment in that military tent. So when they should move, were about to move him into the hospital from this military tent they had put up, the hose to the oxygen didn't fit, so he died just because of that. And still, this military tent cost enormous amount of money and was never used really. I can show you this. I know it's not translated, but if you use, I think you can understand if you put Finland, Denmark, Norway, Iceland together, you will have 22,677 deaths. Sweden alone, 23,731. If you say the Swedish approach is great, there's something wrong with you, I can assure you.
Yeah, that's just very interesting because I had somebody tell me only this week that the excess deaths in Sweden were, you know, one of the lowest figures in Europe, and I mean that's being bandied around at the moment in the debate. Sundararaman, I wanted to ask you, because you've referred to this as well about you know, public adherence, non-adherence to any attempts to control mitigation or to have no mitigations and so on. And going forward again, you know, this is going to be a debate about whether to have any form of control or lockdown or whatever for any future variant. I mean, what's your opinion on this? I mean, based on your experience in India.
So there are two things. One is COVID appropriate behavior as regard to individual protection, masks and social distancing. And the other thing is the question of restriction of movements. Now, en masse, I think we can do much better with more modern behavior change communication on that. I really think that the problem is that one size fits all, one situation fits all. I mean, just wear masks and without some advice of when you can take it off, when you can relax, situations which are relatively safer, and when masks are imperative. You know, at some point, without having a differentiated thing, a sweeping thing, I think is a problem. And also a certain amount of understanding for people who are in different circumstances, and some degree of help also. We see this, for example, if you're getting into a flight, if you're not wearing a mask, the hostess just gives you a mask in your hand, and then you insist that everybody wears the mask. It happens. But in another situation there, you do that in, you can't do that in a town bus, because that sort of support is not there. So there are ways in which we should look at it. But containment, restraint, I think we need to develop much better guidelines on what and when. most of these were highly stigmatization. We had a paper on stigma and denial, led to a phenomena of mass denial. No, there's no such pandemic in the thing. People went and got tested and therefore they became positive. They should not have gone for testing, as if the act of testing caused the disease. Bizarre sorts of behavior issues, which were partly coping mechanisms. Partly coping mechanisms. So I think we need to have taken, for example, the public transport. When we shut down the public transport, the migrant labor were then in confined spaces in the cities, okay, where the disease festered among them. And then if we had allowed them to go in March 2020, a few cases would have gone. At that time, the whole country had only 400 cases. But when we finally allowed them to disperse, there were thousands of cases there. So we didn't have ground rules of containment. And then you had things like putting a steel barricade, iron barricade on the doors of the houses where there is COVID-19, putting yellow tape across. Recently, in this current epidemic. So, and most of this would happen on the poor. So if nobody would think that the domestic servant coming into the household is at risk for infection, they would rather think that the person in the apartment is in a risk from the domestic servant. But the disease came in from international travelers. It did not come in from the slums. And I think that the whole thing has not been thought through. So it becomes an issue. So generally, unlike, I see this across we've done case studies across many countries as part of my global health systems thematic work. And countries which have largely unorganized workers, large slum populations, poor people, the left was very often the democratic left was very often against restrictions. And there was militarization. There were police brutalities in the enforcement of lockdowns. It was about protecting the elite from the mass. Okay, that logic applied. Whereas in a place where there is a more organized left and there is social security and there is unemployment leave and there is a thing, then it was the working class that actually defended the necessity and demanded a longer lockdown. So I think we have, but my greatest concern is we haven't even learned the ground rules. This is a different game. Earlier you had quarantine. People who had at risk of transmitting diseases, they were confined. The general population was not confined from the disease. The disease was confined from the general population. If you've changed the rules of the game, then let's rewrite the rules of the game. But we don't have, so it's a lot of anarchism over here. I think this is one of the big problems, that despite the world having faced such a thing, we still haven't got the ground rules in place.
And that will be amongst the subjects you'll be discussing when you come to London, isn't it?
Yeah, absolutely.
Yeah, well, I think I told you I'm hoping to see you next month when you come back, because I won't be around when you're in London next week. Are there any other questions for Roger or Sundararaman? I have a quiet audience today. We normally have a lot of people asking questions.
I could share you this as well. This is Miss C cases among children. As you can see, Sweden is one of the highest in the world. UK, unfortunately, have more, if you count per million, as you can see. But Sweden is among the top in the world with Miss C cases. This is also because of the strategy. I mean, we never have any real mitigations in schools. They did close schools quite much because of outbreaks. Teachers and children got sick, so they was forced to close down. So we actually have more, the schools in Sweden was actually more closed than the average in OECD countries. But they say we didn't close schools, but that's not true either.
Yeah, I'm not surprised to see the figures there for England were high, the highest. It's followed by Sweden because, you know, I mean, under the Johnson government, only when they were absolutely forced to act did they do something, and they very much folled a Swedish model in the beginning.
Yeah,
and some would
we
argue
had the same strategy really, except UK did a lockdown, and you got the cases down quick, really quick, but then you, like the rest of the world, adopted the Swedish strategy. But however, despite that, even the other Nordics have loosened up and don't have any real restrictions, the deaths are quite lower, much lower.
Yeah. Well, I'd like to thank both our speakers today very, very much. It's been a very interesting meeting. A lot of issues have come up, you know. I'm particularly interested in Sundararaman's point as well about the social and economic aspects of the poor. And, you know, it's one of the issues that we've been pushing all the time about sick pay and improvements to sick pay and so on, and the impact on the poor of, you know, health containment measures. So I think Joan has put in the chat about our next campaign call. Do you want to say anything very quickly about that, Joan?
Yeah, we've been having to jump around which days we have the campaign calls. They're usually on the second Monday of the month, but next month it's the second Monday is a bank holiday, so we've moved it to the third Monday. And today's was changed because of having international speakers. One has to take account of the time differences. So next one, we've got two speakers, Dr. Sally Witchell, if I spelt it wrong, I think, and Lara Wong. I was typing those really quickly. And both, well, Dr. Witchell has focused particularly on disability issues. And as she pointed out to me, and I absolutely agree, because I am myself clinically vulnerable, you're not necessarily clinically vulnerable if you're disabled, and vice versa. And so she is a disability expert and will kind of wants to raise some of the issues that have come out of the pandemic, and now that how different groups have become isolated and changed in the process. Lara Wong is the founder of the Clinically Vulnerable Families group, and they've set up this petition, which we heartily agree with. And it's one of those petitions for government as opposed to one of one of the campaign groups. So it's really important that they get as many signatures as possible. If they get 100,000, then they can get a debate in Parliament. But we've been really, really worried as individuals as much as a campaign about a lack of masking in hospitals and healthcare settings. It does seem to vary from place to place. But some places are really, really bad, and some healthcare professionals tend to kind of shrug it off totally and tell people not to wear masks. So we think that's a really, really important petition, which we will back, and we want everybody to kind of sign it and share it around as much as possible. And I put at the top of the bit I posted in the chat how to get in touch with us, our website and our email list. So, right, thanks very much.
Well, once again, thank you very much, Sundararaman and Roger, for what's been a very interesting discussion. And yeah, I wish everybody a nice evening and see you all soon.
Thank you.